This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
This episode was recorded in the spring of 2022, prior to the 2022 AMI and Ottawa conferences in Lyon, France. Very exciting today because we have a very special guest with us. I can reveal that most of the time today will be a talk about assessment in healthcare education in some form or fashion. If you would look up educational assessment, you would likely find that it has to do something with a systematic approach of evaluation, either that is knowledge or skills or attitudes or beliefs. And while most of us likely think of individual tests as assessment, it does not have to be limited to that. Today we are joined by Professor Ronald Harden. His list of accomplishments and titles is so long that we really cannot do them all here. But let me say that Ronald is a medical doctor by training, a professor of medical education at the University of Dundee, and he's also the General Secretary for the Association of Medical Education in Europe, which has really grown to become a global organization by now. As one of the most celebrated professors in medical education, he served as Dean and Director of the Centre of Medical Education and the University of Dundee, and Director of the Educational Development Unit of the Scottish Council for Postgraduate Medical and Dental Education. And for the first time in our podcast, we are actually honoured to have a guest here that for all his work has been awarded the title Officer of the Order of the British Empire. Wow. For many of the listeners, it may be helpful if we also mention that Ronald Harden is seen as the father of the OSCE, the Objective Structured Clinical Examination. Welcome to our podcast, Ronald.
Thank you for that. Thank you for that kind introduction, and I'm delighted to be able to join you for this podcast. So, thank you for the invitation.
Our pleasure, and we're so looking forward to having you. And having you in this podcast is a true honor, Ronald, especially for someone like me with an educational background. And with such a distinguished history in education, I really cannot resist looking backwards a little bit before addressing some of the more current and future challenges. Could you tell us what it was that really got you interested in assessment of clinical competency in the first place?
Well, as a teacher at the University of Glasgow in the clinical scene, I was involved with the final examination, and it seemed to be there was a problem that some students who I thought should pass the clinical examination did rather badly, and some who did well I wouldn't want to see as my doctor. So there seemed to be a problem with the clinical exam, and indeed this is going back to the 1970s, and there's a general concern about the clinical exam. John Stokes, an eminent physician in London, wrote, for example, in an ASME book that it's the sacred cow of British medicine. We all follow this clinical exam, but it's unreliable. And I was interested to test that theory, and I got a number of students and a series of short cases and a number of examiners, and we got them each to match the exam, to watch the exam and to score it. And it was amazing watching the same examination, the range of scores awarded by these examiners. So it seemed to me there really was a problem in this clinical examination, which was seen as critical when you graduated a student.
And I guess especially in this particular profession, we are all very interested in the candidates being strong. So, but based on this then, why was the answer to these challenges, as you see it, the development of what we today know as the OSCE?
Yeah, well, it seemed we had a problem here, and there were two ways of proceeding. One approach, and this was really what happened in the States, they said, look, this is so unreliable, this instrument. We've got to be able to defend in the courts and to the public our examinations, and this just doesn't work. Whereas we've got multiple choice questions, which are easy to administer. We usually can defend them and they're absolutely reliable. And Hubbard and others set up a group in the States who reviewed the clinical examination and said this just isn't an appropriate assessment. And the whole move was to a written multiple choice question assessment program. But this, to me, seemed not appropriate. I mean, I wouldn't like to think, for example, I was being treated by a patient who did very well on an MCQ exam, but did he have the clinical competence or not? That it seemed to me the only way really of watching that someone had the right skills was to actually watching them perform. The thing I said at that time, the story I said was, just imagine that you to test someone tying their shoelaces, and you could get them to write an essay on tying shoelaces or write multiple choice questions on tying shoelaces. But really, if you wanted them to watch them tying their shoelace, there was only one way to do it, and that was to actually watch them doing it. And I think it's the same I felt in the clinical examination. Could someone communicate? You had to watch them communicated. Could someone test this particular reflex? Watch them trying it in practice. So it seemed to me there was no option but to have some form of assessment that watched the students actually perform a performance examination. And the OSCE, therefore, was introduced as such a performance, an examination that could watch and test people performing the range of skills you were expecting of a doctor.
Yeah, I can easily relate to this. I formerly did teacher as education, and it's something weird about assessing a future teacher based in the classroom based on what they write. We should absolutely see them there. But in your view, why did the OSCE become established as the gold standard then of clinical assessment?
I think in the first instance, it was seen as addressing a practical problem. This wasn't just some theoretical issue. Everyone could identify with this problem that we want to assess the clinical competence of our graduates. If we're going to a doctor, we want to see that doctor has been tested, has the necessary competence. And the OSCE clearly did that. It was a performance exam. It tested the sort of competencies people were expecting to find in a doctor. I think secondly, it was flexible. It's a very practical approach that could be applied in different contexts. I'm still amazed. I quite often get invited to visit OSCEs, and I still get impressed with the innovative approaches one finds that people have adopted different ways to suit their own particular situation. So it's got great flexibility. I think thirdly, it tested a range of competencies. It wasn't just picking, as in the traditional clinical long case, one or two areas to test the students' abilities in. You could test a whole range of competencies. In today, we've got 25 stations, so testing a whole range of competencies. And that these could be tested with a range of patients. You could have some real patients in the exam. You could have some simulated patients. You could use simulators. So it's a mixture, depending on the station, of a range of patient simulations. And I think finally, it could test a range of the different competencies expected of a doctor. I did a study of all the papers written a few years ago, and at that time about 2,000 papers had been written on the OSCE. And I looked at against a list I had in terms of the Scottish doctor of the range of competencies expected in a doctor, whether it was the physical competence examination or the behavioural or the problem solving or communication skills, or even the attitudes and ethics. And you find almost all of these competencies were attested by one or more people in the OSCEs. Even more recently with this emphasis on cultural competence. Elizabeth Kacher in New York has an OSCE testing cultural competence. So I think it's been an attractive model that could be used in a range of settings, but to test a wide range of different competencies.
It brings up a question with me, and I like what you said about the creativity when you were invited to OSCEs. Could you give some examples of creative ways you've seen OSCEs been used?
Oh, I remember once when I was in Thailand, and we were looking at one exam on suturing, and they had some pig legs of animals in to students to use these in the exam. Then after the exam, I said, "What happened?" And they took them all away and used these to make for their dinners for their next meal. So it's using of different of ranges.
But so it also begs the question, though: can you think of areas or themes where OSCE is not really appropriate?
I think not. I mean, I think that this is what interests me in this analysis of the literature. If you look at this list of all these, in fact, I was using the 12 different domains of the Scottish doctor, and every one of these domains, whether it was attitudinal or whatever, you could find an example of an OSCE. And there was one, for example, in terms of what was students' behaviour to health promotion. There's an increasing emphasis that we should be encouraging not just managing as doctors diseases, but there to promote health. And of course, in the written exams, students would obviously all say, you should not smoke, you should lose your weight and all the traditional things. But did that infer what they would do in practice? So I saw one OSCE station where the student in the first station had to read about the records of a patient who was going home after a myocardial infarction. And at the next station, you had to meet the patient and his wife and tell them all about his illness and what he had to do. So at the next illness, we watch what did the actual student say to the patient and his wife. And many spent much of the time talking about the diagnosis, what was the problem he had, the drugs he was on, and the prognosis. But the good student also spent some of the time talking about his lifestyle. What should he actually do about exertion, even about sex? What should he do about smoking? And how much time in that interview, that 5-minute, 10-minute interview, did he spend talking about that? And that was a measure of the behaviour of the student. Attitudes, I think, you can measure what people choose to do. And these students' attitude to health promotion, which we're wanting to encourage, were those students who spend a large bit of that 5 to 10 minutes talking about it. Other students spend very little time, and yet they knew it all. They got all the MCQs right about it. But in practice, they didn't implement it. So I think just an example of how you take something like that is unusual and to find. Another interesting station that also struck me was one about errors in practice. And, I think it's one of the issues. What do we do about errors in medical practice? Sadly, they do happen. And in this station, the student was confronted with a letter from a patient who had gone home from the hospital, and in the letter it said that she was 12 stone 6 pounds. And she said, look, this is ridiculous. I'm only 11 stone 6 pounds. So the hospital's made an error in writing my weight down. And you then had to, in this OSCE, interview people and find what was the error. And was it that her perception was wrong and her standard, the chemist's scales? Or was it that the transcribed kilos to pounds wrong? Or was it that someone just made a mistake writing it down? Or they not actually weighed her? So what was, and you to find out what was the error? So it was actually this, not just writing an essay on errors in practice, but could someone, given a situation where that was a small error, but it was actually, how would you work out what had gone wrong? So I think there are all sorts of these interesting things that we might neglect in traditional assessment. You actually, if you're innovative, you can develop an OSCE station to do that.
This is a podcast from Laerdal Medical.
Yeah, and in that particular case, it struck me it was actually a flattering error. But that aside, I wonder about the abbreviation itself, OSCE. So objective, structured, clinical examination. the objective and the structured, those are particularly interesting. Could you say more about those two words and how they are implemented to actually be objective and structured in this kind of examination?
Yes, the aim is to be objective in the sense that one has decided in advance what one's looking for, what outcomes will be tested, and which station will test which outcomes. So the first decision is what will actually be assessed in the examination. And I still remember warmly the discussions we had prior to an OSCE where the professor of general practice and the professor of surgery were discussing what was reasonable to assess in terms of a patient with abdominal pain, what was theoretical and what should be assessed. So it's objective in first of the decision, what will we actually assess? But then once you've decided that, how will that be assessed at a station? And to work out what are the competencies that the examiner should be looking for. And it may be a checklist or just a global rating scale, but what would you expect to be assessed in that situation? And that is decided in advance. So in that way, it's objective. And it's structured in the sense that you have an examination where the range of competencies are assessed. And for each station, you have almost a blueprint against every station in the exam. You've against what are the outcomes being assessed at that station. So it may be of the 25 stations, 6 are testing an aspect of communication skills. And in different settings. So it's structured that you can assess a range of competencies in a structured, ordered way.
Yeah, I really applaud this. But I guess it also brings me to sort of more the current trends. And I wonder if, I'm curious to hear how you see OSCE fit with some of the more recent trends in assessment as you see it.
Yeah, I think it's a great question. And, I think some people say, look, the OSCE has been going now, I first described it in 1975, so that's many years ago. Is it now filled its time and really should we move on to other methods of assessment? And I think, no, I think the OSCE can be adapted and can still contribute and fit in with some of these trends. I mean, in our book, The 8 Roles of a Medical Teacher, I was pushing the role of the teacher as an assessor. I could even argue it's one of the most important roles we have as a clinical teacher is assessing our students' competence. One of the most important roles. And I described in this what I call the assessment profile, 7 of the trends in assessment. And, where do you want to be on these trends? And then charted the OSCE is very much contributing to each of these trends. I think the first trend was the move to a much more programmatic assessment, where assessment was based not just on a single photo shot of one particular event, and you made a decision on that, but collecting evidence from the whole program. So if you take communication skills, for example, you wouldn't just have one exam testing communication skills. You would collect the evidence from how the student got on in the problem-based learning, how they got on in the wards, but how they got on in the stations in the OSCE. So the OSCE contributed to each of these decisions in each of the domains that you're trying to assess the student on. So this moved to an integrated exam that had evidence, just as in a court of law, you would have evidence from all sorts of sources to make a judgment. And the OSCE would contribute. Some people say to what's the best exam? And maybe they expect me to say an OSCE. And I say, no, very much it's a mixed economy. It's a range of tools. The good examiner has a range of tools. And the OSCE is one of the tools, and it can contribute to the programmatic assessment. The R in the profile was relevance, the move to wanting much more authentic assessment, testing the outcomes that really relate to real practice. And of course, as I've suggested, that was how the OSCE started. It was all about looking at real, it's simulated practice, whether it's a simulator or a simulated patient, a real patient. In some ways it's simulation, but it is actually identified as authentic in the student's mind as real practice. So I think it is very much still contributing to relevance. and other outcomes such as cultural competence, for example. And the O in the profile was outcome-based. And as I suggested, I think it's one of the advantages. You can look at what are the competencies you can expect of a doctor and how are you going to assess these at OSCE stations. The F is in the profile is feedback. That, I think it's been changed, the whole notion of assessment, not just to assess is someone able to go on to the next grade or to pass and graduate as a doctor, but there to help them learn and to give them feedback and contribute to their learning. And I think the OSCE is very much in that line. I remember asking our students when I was dean in Dundee what was the most memorable, powerful learning experience they'd had in the last 6 months. And we'd rather a nice new neurologist who was rather theatrical and gave marvellous lectures. And I thought it might be some of his performances. They liked that, but what many of them put down, it was the feedback they got after they did their end of term OSCE. They did an OSCE, and immediately after the OSCE, they met in their groups and met with individual examiners, and they saw their score sheet, and they saw what they were capable of doing and what they were not. And this, they said, was the most powerful learning experience they'd had in that previous 6 months. So feedback. The I is the impact, and the profile is the impact of the assessments. They're not just there to test the student or to give feedback, but what impact will they have on the student? And again, I remember in the OSCE thinking about when we first introduced it in Dundee, the librarian came to me, see me, said, "Professor Harden, something odd is happening." I said, "Oh, what is it?" She said, "Well, normally before the final examinations, we get a whole lot of students coming in, filling all the books, reading all the books before the final exam. This year, it's empty. Where are all the students? Why are they not in the library?" And the reason was, for the first time, the students were having an OSCE for the final exam. And they knew they didn't, the impact of the exam wasn't to make them learn more from the books, but was to go into the wards and learn the clinical skills. And same way with the L, the learner's much more engagement. The OSCE is involved with the students doing mock OSCEs, and evaluation. The OSCE is assessment and is a fair assessment. So I think all of these trends I identified in this assessment profile that are reflecting assessment where we're going in the years ahead. The OSCE still has a very important role to play, not as the only assessment method. We need a mixed economy, but it is there as one of the tools.
So I need to chip in another question here, because you raised something very interesting. You said assessment for learning, and of course that's what normally is known as formative assessment. The summative part is, of course, where it's your capstone or your high stakes or you're out. But so have you come across institutions where they use OSCEs more structurally or systematically also for learning purposes, where the students are allowed to practice the OSCEs up front? Is that common?
I think it's a great point, and I think it's increasingly common. And I think students are now, we just had a couple of papers in Medical Teacher just last week, for example, where students were setting up mock OSCEs. The students were organising them for that purpose. They were so important, and they got a little bit of help from the staff, but the students were actually arranging mock OSCEs with that very much in mind. Nice.
So, one of the things you're famous for and known for, Ronald, is of course the big and renowned conference, the AME conference. And I'd like to shift gear and talk a little bit about that, because in late of August this year, the Association of Medical Education will yet again arrange this highly regarded AME conference. And this year it's going to be in beautiful Lyon, in southern France. And in tandem this year, there will also be the Ottawa conference, focusing particularly on assessment. What are your expectations for the conferences this year?
Thank you. It's first of all, it's a great things we look forward to, we're actually having the conference. I really feel over the last 2 years, okay, we've had virtual conferences, but it's not the same. And I'm really excited this year. For 2 years now, we'll be meeting face-to-face in that lovely city, Lyon, for both the Ottawa conference, which started off with, incidentally, when think of OSCEs, it was Ian Hart from Canada was a visitor in Dundee, spending a sabbatical with me, and he said, look, we must take this Ottawa, this OSCE, and demonstrate it in the States, because, as I suggested, they'd gone down a very different route, much more emphasis on MCQs and not clinical exams. He said, this is all wrong. And in 1985, we ran the first Ottawa conference featuring the OSCE as an assessment tool. And that was so successful. Every second year since then, we've had this conference, which inherited the name, the OSCE Conference, looking at performance assessment. So I think it is, this year, again, we'll be meeting, looking at performance assessment in the OSCE and how some of the approaches to measuring assessment of attitudes. And one of the, I think, exciting new features that we're all looking at is even exams for assessment purpose, for selection purposes. Because you could say that the selection of students, many more students want to come into medicine than are able to be accepted. So how do we select the student who will be the best doctor? And I think there's increasing evidence looking at the different selection methods. It's the most important assessment we do probably is select students. And a modified OSCE we use in Dundee, for example, where we look at the sort of unusual competencies that not normally looked at selection. It's usually just academic criteria. So we're looking at how do you assess things like grittiness, empathy, resolve, even kindness, problem solving. So it's looking at some of these new ideas in the OSCE. But in the main AME conference, again, it's exciting because one hears about these new developments that people are applying in practice in their own situation. And I think one of the most, significant trends I see is a changing role of the teacher. If somebody asked me when I was appointed as an endocrinologist, as a teacher, I was there to pass on my knowledge of endocrinology to the students. That was my role. I taught them all endocrinology I knew or thought they should know as an information source. And I think we're now realizing it's a very different role where they're much more as a curator of learning and facilitating and helping students. And gosh, isn't this become so important during the COVID pandemic? So I think that's helped us reframe education. It's been a chance to rethink education. And this role of the teacher is more than just an information provider, whether it's live or online lectures. It's much more, how do they facilitate learning? How are they a role model for the student? How are they, as we said, an assessor? But also the role of the student is changing too. The role of the student is becoming someone who's preparing themselves for their own lifelong learning. My grandson was just going to do medicine. Asked me what we have to learn, and I was thinking, gosh, he's going to be practicing medicine potentially in 35 years' time, longer. What will medicine be like in 2070? If he's a good doctor, it will be because he's kept himself up to date. It's not what he's been taught now at medical school this coming year. So I think this changing role of what's expected of the student, what's expected of the teacher is kind of one of the big themes running through the conference. And obviously the other demands now that are much more in the front. How do we deal with climate change and sustainability as a theme in medicine? Or civic professionalism as a teacher? We're not there just, are there bigger issues like gun violence that is an issue that we should be addressing? So other these more uncomfortable areas, as well as just the technical things of how do we actually manage that individual patient? So I think there's some exciting things happening.
Yeah, and funny you mention, I just read, I think it was something like the global burden of stroke, a document the other day, and it was actually mentioned that pollution is now moved up to the third or second place in causes of stroke. So I think what you're hitting straight on the nail. I really want to thank you sincerely for joining this episode, Ronald. It's been an adventure of an opportunity to have this chance to look backwards and a bit forwards. So thank you so much for joining our podcast, and hope to see you in Lyon.
I look forward to that, and I thank you again for the invitation and the privilege of sharing some of these thoughts with you.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.